Welcome back to the deep dive. Today we're zeroing in on a really significant global health challenge, chronic painful knee osteoarthritis, or OA.
It's incredibly common, isn't it?
It really is. If you look at the stats, it's something like 23% of adults age 40 and older are dealing with this. And, for anyone suffering, the goal is pretty straightforward. Find something effective, non-surgical, long-term that gives real relief without needing pills all the time.
Absolutely. Something sustainable.
Okay, so let's unpack this listener question we got. They're curious about a newer intervention, sounds quite promising, involves tiny needles. But the key thing is, how often does it need like a top-up to keep working?
Ah, the maintenance question.
Exactly. Is it something you do once and you're good, or is it, more like a monthly commitment to keep those benefits going?
Well, that's precisely the question a really large, multi-center, randomized clinical trial set out to answer. We're diving deep today into a study looking at something called periosteal and intraarticular electrical dry needling, or PIEDN for short.
BD.
And the mission was very specific. Compare the long-term effectiveness, specifically over 30 weeks, of different booster schedules. So a monthly booster that's every 4 weeks versus a bi-monthly one every 8 weeks. And compare both to a control group that didn't get any more treatment after the initial phase.
Right, so finding that sweet spot for dosage.
Exactly. And quantifying just how effective PIEDN is on its own for knee OA.
Okay, before we get into the trial itself, we really need to define PIEDN because, when people hear needling, they often jump straight to traditional acupuncture. But this is different, isn't it?
It is fundamentally different. Dry needling in general uses those thin monofilament needles for therapy, but PIEDN is very much a Western medical approach. It's anatomically targeted, focused purely on musculoskeletal physiology.
Not on, like, meridians or chi.
No, not at all. It uses electrical stimulation and doesn't rely on Oriental medicine concepts or diagnoses. It's about nerves, muscles, inflammation, that sort of thing.
Got it. And the technique they used in this particular study sounds quite specific, maybe even a bit aggressive compared to other treatments. Can you walk us through that?
Yeah, it's quite an intensive technique. Two main parts. First, they target the periosteum, that's the sensitive layer covering the bone, and they do that using repeated sort of bone tapping or thrusting with the needle.
Tapping. Okay.
Yeah. And second, they did 4 precise intraarticular needle insertions. That means the needle actually goes into the joint space.
Whoa. Into the actual joint capsule.
Correct. Usually about 25 to 35 millimeters deep. They use landmarks like the infrapatellar sulcus, medial and lateral, to guide them and make sure they're inside the joint.
Okay. Bone tapping. Needles inside the joint. That sounds, well, intense. Maybe even painful. How do patients tolerate that?
Well, that's where the electrical stimulation comes in. Once the needles are in place, they're left there for 30 minutes. And during that time, they get high-intensity electrical stimulation, but at a low frequency, 2 hertz in this study.
High intensity.
Yeah, delivered at the maximum intensity the patient can comfortably tolerate. So yes, it's a serious intervention, but the idea is to maximize the pain relief and the physiological effects.
Right, the payoff needs to be worth that initial intensity, I guess.
Precisely.
And speaking of payoff and reliability, this wasn't just a small study in one clinic, was it? That seems important for the findings.
Oh, absolutely critical. The scale here is impressive. They enrolled 586 patients who met the official criteria for knee OA, and they did this across 64 different clinics.
64 clinics, wow.
Yeah. When you see a trial spread that wide, it really boosts your confidence that the results aren't just some fluke from one specific setting. It means they're more likely to apply to, the general population with knee OA.
Okay, so a large, diverse group, and everyone started off the same way. Tell us about that initial phase.
Right. Before they split into groups, all 586 participants went through a standardized initial treatment phase. This involved 8 to 10 sessions of the full 23-point PIEDN protocol spread over 6 weeks.
Why do that first?
Well, 2 main reasons. First, it ensures everyone included in the main part of the study actually responded positively to the treatment initially. And second, it establishes a consistent baseline level of function and pain relief. From there, they could properly measure how well the different booster schedules maintained those initial gains, or how much things decayed without boosters.
Makes sense.
Yeah.
So after those 6 weeks, then came the big question: how to maintain that improvement?
Exactly. That's when the randomization happened. Patients were randomly assigned to one of 3 groups for the next 6 months, bringing the total observation time to 30 weeks.
Okay, the 3 groups again were?
Group 1 was PIEDN4, They got a booster session once every 4 weeks. That was 195 patients. Group 2, PIEDN 8, got a booster every 8 weeks, 197 patients in that group. And group 3 was the control group, who received no more PIEDN sessions after the initial 6 weeks. That was 194 patients.
So you've got monthly, bi-monthly, and nothing, really isolating that frequency factor.
Precisely. The only difference between the groups was how often they got that PIEDN booster.
Okay, so we have the setup. Now, how did they actually measure if it was working? What was the main outcome they tracked?
The primary outcome was related disability and function. They used a very well-respected questionnaire called the Western Ontario and McMaster University's Osteoarthritis Index, or WOM.
Ah, yes, the WOMA, common in OA research.
Very common. It gives a score from 0 to 96. And importantly, a lower score is better. It means less pain, less stiffness, and better physical function.
Right, but just seeing a number change isn't always enough, is it? How do we know if the improvement actually makes a difference in someone's life?
That's a crucial point. We need a benchmark for what's clinically meaningful. And for the WM score, that benchmark is called the Minimum Clinically Important Difference, or MCID.
MCID. Okay, what's the value?
For the WAC total score, the established MCID is 16.1 points. So if a treatment helps someone improve their score by 16.1 points or more, that's considered a change that they would likely notice and feel is significant in their day-to-day life.
Like being able to walk further or get out of a chair easier, things like that.
Exactly. It's not just a statistical blip, it's a real-world improvement. So we're looking for results that clear that 16.1 point hurdle.
Okay, that sets a pretty high bar.
Yeah.
Now, just to give us some context before we hear the PIEDN results, how does this compare to, say, standard conservative stuff like exercise or maybe general acupuncture?
Good question. It helps frame the results. So if we look at exercise therapy, which is often the first recommendation, studies generally show fairly small effect sizes. For pain, the standardized mean difference, or SMD, is around 0.24. For function, it's even smaller, maybe 0.15, usually measured at 2 to 6 months.
Small effects. Okay. What about general acupuncture?
General acupuncture tends to do a bit better. Pooled data suggests an effect size, an SMD, of around 0.58 for pain relief. That's generally considered a medium, solid effect.
Okay, so small for exercise, medium for acupuncture. Keep those numbers, 0.24, 0.15, 0.58 in mind. Now, let's get to the main event, the 30-week results from this PIEDN trial. Let's really focus on that PIEDN-4 group, the folks getting the monthly booster.
Right. And this is where things get, frankly, quite dramatic. What the researchers found was striking. The monthly booster schedule, the 4-week interval, was overwhelmingly superior.
Superior how?
Patients getting PIEDN every 4 weeks maintained significantly greater improvements on that main WOMAC score. So better function, less disability compared to the 8-week group. And the difference compared to the control group, the ones who got no boosters, was huge.
Huge. Can we quantify that? You mentioned standardized mean difference, SMD, earlier.
Okay.
What was the SMD for the PIEDN-4 group compared to control at 30 weeks?
The between-group effect size for the PIEDN-4 group on the WOMAC total score compared to the control group at 30 weeks was an SMD of 1.32.
1.32.
Yes, 1.32, with a tight 95% confidence interval, by the way, from 1.6 or 1.54.
Wow. Okay, put 1.32 into context for us. You said 0.8 or above is considered large in physical medicine research.
That's right. An SMD of 0.8 is typically seen as a large effect, kind of a home run result. Getting an SMD of 1.32 is, well, it's massive. It essentially means that the average patient getting the monthly PIEDN booster was functioning better at 30 weeks than about 90% of the patients in the control group.
Better than 90%. That's staggering for a non-surgical treatment for something like chronic OA.
It really is an exceptional result. And importantly, let's connect it back to that clinical relevance, the MCID.
Right, the 16.1 points. Did the monthly group clear that bar compared to control?
They did. The average difference in WOMAC score change between the PIEDN-4 group and the control group was 16.9 points. So it didn't just meet the MCID threshold, it actually exceeded it. This confirms that the monthly booster provided a lasting, genuinely meaningful improvement in function over the full 30 weeks.
So the equipment really paid off for that group. Now, interestingly, you said the 4-week was superior to the 8-week group. But how did the 8-week group do compared to doing nothing? Did the bi-monthly booster still help somewhat?
Yes, it did. The PIEDN-8 group also showed significant improvement compared to the control group. Their effect size, the SMD, was 0.72, so still a medium to large effect, definitely better than nothing.
Okay, 0.72 is still decent, better than the 0.58 you mentioned for general acupuncture?
Right. It tells us that the initial intensive 6-week treatment provides a pretty durable benefit on its own, but that benefit clearly decays faster if you only get a booster every 8 weeks compared to every 4 weeks.
So the 8-week top-up helps slow the decline, but the 4-week top-up really maintained that peak benefit much more effectively.
Precisely. That 4-week interval seems critical to kind of continuously interrupt whatever physiological process leads to that functional decline after the initial treatment wears off.
Okay, that covers the main function outcome. What about the other things people care deeply about, like pain and stiffness? Were the results similar there?
Absolutely consistent. The PIEDN 4 group, the monthly boosters, also showed significantly greater improvements in all the WOMAC subscales. That includes pain, WOMAC-CP, stiffness, WOMAC-CS, as well as the physical function component, WOMAC-PF.
Indirect pain scores.
Yes, they also measured pain intensity using the standard numeric pain rating scale, the NPRS, 0 to 10. And for the PIEDN-4 group compared to control, the effect size for pain reduction was also exceptionally large. It came in at an SMD of 1.1 Phi.
Another massive effect size, over 1.0 again, so high function, low pain, really the ideal combination.
Then the full package, yeah.
And, less pain often translates into something incredibly practical that impacts millions. Taking fewer pain medications or maybe none at all. Did the study track that?
They did, and this is perhaps one of the most compelling real-world findings from the study.
Okay.
At the 30-week mark, they looked at how many patients had completely stopped taking any pain medication for their knee OA. In the PIEDN-4 group, the monthly group, 63.1%, almost two-thirds, had stopped all pain meds.
63%, that's huge. How did the others compare?
Big difference. In the control group, only 21.1% managed to stop their pain meds. And even in the PIEDN group, the bi-monthly boosters, only 39.1% stopped.
Wow. So the monthly booster didn't just improve function and pain scores, it dramatically increased the odds of getting off medications entirely. That has huge implications for avoiding side effects, long-term risks, addiction.
Absolutely. Reducing that reliance on pharmacological management is a major goal in OA care. This suggests the monthly PIEDN schedule is incredibly effective at achieving that.
So if we sort of zoom out and look at the bigger picture for managing chronic conditions like OA, what does this study really tell us?
Well, I think it strongly validates the concept of extended care models, or what some call booster visit care, for chronic musculoskeletal problems. It demonstrates with pretty high certainty the optimal dosing schedule needed to maintain the significant long-term benefits achieved with an initial intensive PIEDN protocol.
And that optimal dose is clearly monthly.
Yes. The 4-week interval was shown to be required to really sustain those large initial gains. It highlights that maybe we should think of OA not just as something you treat acutely, but as a condition requiring regular, targeted maintenance for the best possible long-term outcomes.
And we should probably touch briefly on why this might be working so well. What's the thinking behind how sticking needles near the bone and joint and stimulating them electrically produces these results?
The exact mechanisms are still being fully worked out, but the thinking is it's likely multifaceted. Research suggests this kind of electroacupuncture might locally block the release of key pro-inflammatory cytokines, things like interleukin-1 beta and TNF-alpha, which are known drivers of the OA disease process.
So calming down the inflammation right at the source.
Potentially, yes. And by reducing that local inflammation, it might also improve local blood flow, microcirculation, and perhaps even encourage some repair mechanisms within the cartilage itself. It's complex, but the effects seem to be happening right there in the joint environment.
Fascinating. Okay, let's try and summarize the key takeaway for our listener who asked about this.
Right. I think the bottom line is this. For individuals dealing with painful knee OA, this large, well-conducted trial shows that receiving PID followed by monthly boosters, that's every 4 weeks, is a significantly more effective, genuinely superior way to maintain improvements in function, pain, and stiffness over 30 weeks.
Better than doing it every 8 weeks, and much, much better than stopping after the initial phase.
Exactly. It offers a powerful, evidence-based alternative treatment, especially for people trying to reduce or stop oral medications, or perhaps delay or avoid the need for major surgery like a knee replacement. The effect sizes are just remarkably large.
They really are. An SMD of 1.32 for function is, as you said, a massive result in this field. Which leads me to a final, maybe slightly provocative thought for you, the listener, to consider. We've established the incredible efficacy here. But there's a classification issue. The American Medical Association, for instance, currently classifies dry needling techniques like this, specifically involving intraarticular and periosteal needling, as an invasive procedure. That's different from how they classify things like standard physical therapy, which falls under conservative intervention.
Interesting distinction.
Yeah. So given these results showing PIEDN with monthly boosters is superior in the long term to many traditionally covered conservative options, with effect sizes far larger than typical PT. What impact do you think labeling it invasive will continue to have? Will it affect insurance coverage, access to care, even though the data suggests it's highly effective and potentially reduces other healthcare costs, like medication use or surgery?
That's a really important question about definitions versus outcomes.
It is something to think about. How do we reconcile these powerful new data points showing superior long-term efficacy with existing classification systems and healthcare policies? Worth mulling over.